Hello class, this is the last video that I'm recording for the course. This is the overview video for chapter 22 and it's called Controlling Healthcare Costs. And this is a very important chapter, and I know I've said that about every chapter, but this really is a very important chapter because healthcare costs are escalating and they've been trying to do something about it since 1983. And so this particular chapter, I'm ending the course with this video in this chapter, and I think that I've saved the best for last. Okay, so let's dive right into it. We do have rising healthcare costs. I saw it myself. I was in healthcare for 35 years. And there were times that I was doing the budget and I thought to myself, I don't know how much longer we can sustain this. And this is going back at least 15 years. We have some really wonderful improvements and advances in healthcare. But with those advancements comes a very hefty price tag. What we can do today in healthcare doesn't come for free and it doesn't come cheap. And that's the reason why we've seen nothing but escalating healthcare costs. So how do we weigh this? On the one hand, yes, we want CAT scans and MRIs and PET scans. We want the latest medicine. We want vaccines. We want medicines that can cure everything. On the other hand, we don't want to pay for it. We can't afford the $6,000 a month prescription, the $40,000 a month prescription. What do? One PET scan could run $5,000. How many people do you know that can afford that? So we know what the drivers are in healthcare. The drivers are the technology that just keeps getting better and better and helpful. We have an aging population, which is exploding. And the problem with our aging population is because we're getting so good at treating and preventing medicine and finding illness early, you can expect that we're going to see a lot of people living past 100. Another cost driver, if you will, is specializations. We all go to specialists. Who do you know that needs hip replacement that is not going to want to go to an orthopedic surgeon? Well, for every part of the body, we have a specialist. That drives the cost of healthcare up as well. The cost of drugs, as I said to you, some drugs are $40,000. A friend of mine has MS. Her drugs are incredibly expensive monthly. All right, so and the one last thing that I think may come as a surprise to you, yes, we have an aging population that's probably in the best shape of their lives, 80-year-olds that are in the best shape of their lives. However, we have a youthful population that's probably in the worst shape of their life. I'm amazed when I walk around here in Florida. I walk on the boardwalk and I see these young people with these baby faces who are like 200 pounds. It's just unbelievable to me how overweight our younger population is, this population is. And with weight comes all kinds of problems, diabetes being the one that we all think about. And then the ripple effect of something like diabetes just goes on and on and on and on. And if you're starting at 20, you're going to have a real problem by the time you're 40. All right, so these are some of the drivers of the cost in healthcare. And this is what we have to control, all right? So this chapter starts at the beginning. So it lays out the actual facts of the rising cost in healthcare, but then it lets us know, okay, where do we find healthcare in this field, all right? And they've broken it down to 3 types of service institutions. So one of it is nonprofit institutions, okay? Anything that's considered a nonprofit is more or less a charitable agency. They don't pay taxes. They get exemptions because they're nonprofit. The second type of healthcare service institution would be your proprietary or for-profit institutions. And they operate just like any for-profit business. And what we do know is that over, I'd say, the past 15 years, they've all incorporated. They've become corporate humongous corporate medical centers. And so the structure of the way it's run is totally different. And then you have the government institutions, veterans hospitals, and those are public health care facilities for the most part. And they get their funding from the state, local, and federal government. All right, so those would be the three types of healthcare institutions where all healthcare in this country is delivered. All right, they go into a little bit about the history of reimbursement and stating that hundreds of years ago, you went to the doctor, and if you couldn't pay, you gave them fruit or maybe an animal. There's a great movie, Doc Hollywood, and he finds himself in this, little itty bitty town, and he helps people, and he gets paid in pipes. He gets paid with pigs. He gets, they barter, and that's how it all started, actually. But then the cost started to, you would pay it. If you weren't bartering it and you did have some money, there was a system called fee-for-service. That's the very first insurance system. And then from there, you had insurance, but you never really saw it or filed it. It just kind of happened. Or you paid the doctor, all right? But then what happened is the cost started to go up, and that's where the demand for healthcare started to show itself, all right? Okay, I'm sorry. I just want to look at it and get it right. As the cost rose, insurance companies and other payers questioned the efficiency for fee-for-service as a pricing method. All right, so rather than encouraging savings, they argued it rewarded the providers who prescribed the most services, such as lab tests and diagnostic procedures. So the payers believed that all of the healthcare professionals should be held responsible for the costs. There was a time under this fee-for-service when, as they're saying, providers would gobble up as many services as they could. And one thing you heard very commonly was, I'm going to put you in the hospital for observations for 5 days, 10 days. And nobody questioned the doctor. He would do it and just put his patient in and bill for 10 days worth of services, okay? And so that's an example of maybe excessive use of services, okay? Then the chapter goes on to explain to us this whole healthcare payment methods, and there are how many? 3. So you have direct pay, and in this method, the patient pays for the healthcare costs using his or her own money. You have, secondly, private insurance. Individuals can purchase their own insurance policy, or it could be part of a benefits package from employers. Most people in the United States get their insurance from their employers. It's employer paid, but shared with the employee healthcare insurance. And then there's government funds. You have Medicare, you have Medicaid, you have the VA system, Champus, those are all government programs. So what we're going to do is the chapter goes in very nicely and explains to us the difference between Medicare and Medicaid. And even to this day, people get it mixed up. So let me just briefly, you'll read it in the chapter, but I'll just briefly give you a very simplistic difference. Medicaid is healthcare insurance for low-income people. You have to be making under a certain, there's a calculation, and you have to be making under a certain amount in order to qualify for Medicaid. Medicare is mandatory. You must file for Medicare before your 65th birthday, or there's a fine. There are consequences. And then once you're 65 and you're retired, then you will go on to the Medicare system, which I have it. I think it's excellent. I don't have any complaints about Medicare. I just don't. However, Medicare is for the elderly, and it is for people who have some long-term illnesses, such as kidney failure, long-term kidney disease. But the one thing that most people on Medicare do not understand is that Medicare does not pay for nursing homes. Medicare doesn't pay if you need an aide in the house. That's Medicaid. So in order to qualify, when someone has to go into a nursing home, they have to apply for Medicaid if they don't have it. And so that very briefly and very simplistically is the difference between Medicare and Medicaid. Now, Medicare is known for different parts of the alphabet, A, B, C, and D. And what do those parts mean? So Part A, Medicare, handles all of the hospital claims, all of the hospital stays. Medicare Part is free. Medicare Part A is free. Medicare Part B, however, comes out of your Social Security check, about $100 a month, and that pays for all of the doctors, all of the labs, all of the imaging, but it only pays 80%. So unless you have a supplemental insurance policy with a private insurer like Cigna or Humana or Aetna, you are responsible for 20% of whatever the bill is. Now, Medicare Advantage C is more or less like a HMO that Medicare offers. It's excellent, but it operates just like an HMO. And then Medicare Part D is fairly recent under President Bush, the second one. He saw how people struggled with their medicine, and the consequences of that was they weren't taking their medicine, which made them sicker and having to use more and higher-ended healthcare services. So it was cheaper for the government really to step in and say, okay, we'll cover a lot of the prescriptions, which they do, and there's very low copays. So that's Medicare ABCD. All right? Then how the government got involved in healthcare in the first place. In 1983, the government saw that people were starting to live longer. Prior to that, people would retire at 62 and be gone at 64. The length of age for people who retired prior to 1983 was 2.5 years. You lived 2.5 years after you retired. But then what started to happen is healthcare had better medicines, better diagnostics. You know, the wellness movement was starting, and so now people started to live longer. And so the government saw through their Medicare program, where most people are elderly, that this was not sustainable. So in 1983, they actually went up to Yale, and they asked the students in Yale in a specific math program to come up with a system where they could use it to save money, cut costs. And they did. They came up with this diagnosis-related group. Most of us know it by the acronym DRGs. And basically, what the DRG system did was it classified every diagnosis for why people are admitted to the hospital. They classified appendicitis, they classified gastric ulcers, they classified pneumonia, they classified the measles, they classified everything that could be classified as a diagnosis. These are only diagnoses we're talking about. And so how it works, though, is if you go into the hospital for, let's say, appendicitis, the DRG will pay a flat rate, $4,000, to the hospital to treat that patient. Now, it's in the hospital's best interest to treat that patient for $2,000 because they get to pocket anything over what they can efficiently and cost-savingly treat that patient. However, if they treat that patient for $2,000, send them home, and that patient gets an infection and is readmitted to the hospital, all those further costs are now on the hospital. So they have to balance treating the patient efficiently, discharging the patient safely so they can make money, because if there's a complication, all the costs of that complication, the government isn't going to give the hospital another penny to treat that patient, okay? So they have to be careful, but that's how the DRG system works, okay? Another response to trying to lower healthcare costs was this whole issue of managed care. Initially, it started off as HMOs, and initially it got a bad rap. But like any other new system, you work the bugs out, and today HMOs are a very desirable, and most of us are in some type of a managed care plan. Managed care plans are exactly as they are stated and identified, managing the care. So in managed care plans, the one thing that identifies these managed care plans is that you have what's known as the gatekeeper, or the PCP, the primary care provider. You go to him first, and he decides if you need to go to a specialist. He more or less decides on the care that you need to have. He's also known as the gatekeeper because nothing gets past him, all right? You have these other prepaid plans. This is also managed care. One of them is known as capitation, and how capitation works is that, let's say a doctor's group is in Florida, okay? Let's be more specific, is in Volusia County. And the government will go to them and say, okay, we will give you 5,000 Aetna patients, okay? And for each patient, we will give you $200. Whether you see the patient or not, we're gonna give you $200 per head, flat rate, that's it. So this capitation, at first, it was thought, well, it'll average itself out because there are many, many patients that only go once a year to the doctor. They're getting $200 a month for this patient. But then you have your elderly patients who go and gobble up much more than $200. So somehow in the middle, it's supposed to average itself out. A lot of criticism on this system, and I think they've moved away from it for the most part. Then you have another method of trying to control costs and negotiated fees. So the insurance company negotiates with the physician's office, and whatever is left over, the patient has to pay. Or if the doctor is in the network of the insurance company, the doctor accepts assignment, meaning that the doctor will accept whatever the insurance company pays as payment in full. And I don't know, I would highly recommend you read your EOB, your explanation of benefit system statement, because on that statement, it will show you for a $5,000 PET scan, the insurance company is only going to pay maybe $500. And if the doctor accepts that as payment in full, he's losing $4,500 per patient, per PET scan. So, it seems like they're trying to control costs, but the question becomes at whose expense, okay? Another way that they control costs is this review of systems. We're all familiar with, is it approved? Is this test approved? Is this procedure pre-authorized? That means the insurance company looks at the doctor's notes, looks at the x-ray, looks at whatever's being presented as evidence as to why this patient needs surgery, let's say. And the insurance company will make a determination. Yes, we'll pay for it, or no, we won't. And when it does determine that they will pay for it, that's called pre-authorization. And many times a number will be given that the hospital gets. It's a pre-authorization number. And so the hospital knows, okay, we can go ahead with it. And they will not go ahead with that pre-authorization. That is not going to happen. Okay, this whole issue next in the chapter, and they do a very small job of just covering it, but once again, it's because this is a very broadly based class, but they go into the concept of national health care coverage. I think most students today are under the misconception that it was only in 2010 that this topic, and under President Obama, that this topic was brought up for national discussion. In reality, it's gone all the way back to the 1940s. And there were many presidents who looked at it, tried to figure out how to do it, but then shelved it, either for pressure from the lobbyists like the American Medical Association, or just because this is a very complex country of 350 million people, and states, some are republics, some are commonwealths. How do you get everybody on board? And the way national insurance works in countries such as Britain, they have the National Health Service. How it works is everybody is in contributing to that system. And so, the people who need to be treated draw from that system. The people who don't, who are never treated, young people who never go to the doctor, still contribute to that system. And that's the way it has to work. It spreads the risk. So finally, in 2010, they passed this Patient Protection and Affordable Care Act. And some of the highlights of that bill was that children couldn't be denied. Adults couldn't be denied because of pre-existing conditions. Businesses with fewer than 50 employees received tax credits. Everybody except certain low-income individuals had to purchase health insurance or pay a fine. Medicare drug coverage had been improved. Young adults could be covered now till they're 27. And that's just some of the highlights, okay? Let me see. Among the changes implemented to help create the necessary revenue was that the Medicare payroll tax was expanded. Insurance companies would have to pay a 40% excise tax, and a 10% excise tax would be assessed on tanning services. There's a lot of controversy to this. Now we're on the other side of it, 10 years down the road, and it has worked. In some areas it has worked. In some areas there's been some bugs, which, like anything that's new, has to be worked out. And so moving forward, the discussion became, and it continues to be discussed, does the government owe everyone in the country health insurance? And that's the biggest sticking point with this moving forward, because we will move forward with it. It's, but in place is this, and depending on where you live, depending on what state you live in, it's either wonderful or you have problems with it, okay? Lastly, this chapter covers another and more important way to control costs in healthcare, and it's controlling the expenditures. Now, when we look at expenditures, we're talking about areas in a healthcare organization such as financing, all right? And that means the source of money that a facility needs to run the business, the rent, the lights, the overhead, the insurance, all of that. A big part of that is something called the accounts receivable. You have two accounting functions that go on under financing. Accounts receivable means that's the money that's coming in. That's the money you're waiting for from the insurance companies, from the patients. The other one is accounts payable, and that's the amount of money that's going out, payable. You're paying the rent, you're paying the staff, you're paying the malpractice, you're paying the insurance, okay? All of that is what's really important. Now, needless to say, you want the accounts receivable to be healthy, because you need that money to come in to manage and successfully control the accounts payable. So they've come, years ago, they would just let accounts sit for 120 days. Now the recommendation is accounts receivable accounts should not be sitting there for more than 90 days. So you want to turn around the money that your patients owe you, that the insurance company owes you. And the technology's been a real help with that, getting those claims out to the insurance companies, and the insurance companies using the same technology to pay on the claims. So, but the technology itself is also expensive, okay? The technology and supplies is a cost. So, administrators are constantly asking, years ago they used to keep rooms and rooms full of supplies. They don't do that anymore, because that's all money that's sitting in the supply closet when it could be in the account making interest. So they changed that about 20 years ago, that thinking. The technology costs money. Where you have CAT scans, MRIs, there are some imaging centers that run those 24 hours a day, and it's not uncommon to hear someone going for an MRI at midnight, okay? Facilities of physical buildings, okay, and the land they stand on, and the cost of maintaining the grounds. However, with the movement towards people working from home, I look at that as an area, as do all companies. If they don't need to have physical buildings, that's one place they can save money. And then the personnel labor, okay, that's a big cost. The biggest cost in the personnel labor is what we call the fringe. That's all the benefits, the holidays, the vacation time, the cost of paying for their insurance, healthcare insurance, disability insurance, unemployment insurance. That's all fringe, and that's separate and apart from the actual salary. Another high cost area, okay? And lastly, the last thing that we're going to look at in this chapter is the healthcare professionals' impact on costs. And what the recommendation is that every healthcare professional must take financial responsibility for his or her performance. And they go down all kinds of issues such as your efficiency as an employee, focusing on the job, careful use of your supplies, not taking supplies home for your own personal use. Now, when they get to the billing and coding aspect of this, what they're saying is that you bill and code correctly, and you make sure that the billing and coding is done in such a way that it gets for the practice or the medical center or the imaging center or whatever facility it is, the highest rate of reimbursement. So coding is very specific. And that improper coding can lead to various problems, everything from a loss of income to charges of fraud for overbilling. So coding is a very important area, and it plays a very important part in costs, how we control costs. And then the rest of this chapter just, elaborates a little bit on what I've told you. So once again, here's a chapter that is really, really, really important. It's so relevant. It's going to be relevant way into the future unless and until we can control all the costs. And we're going to be seeing some very innovative ideas, robotics, all kinds of new ways of doing things, with the sole goal being to control the costs in healthcare. So that will end the overview on chapter 22. Now you will have videos in every single chapter, week, and class that you can, these are just overview videos. I want you to use them before you read the chapter. That's the whole goal of these videos. It's an overview, it gives you a little bit of insight, and then you can go and read the chapter. So once again, this overview was on chapter 22. Read it. It's a short chapter, but really critically important. And I thank you, and I will see you soon.